Okay, well, thank you very much. I'm Jeff Conklin. Thank you very much for inviting me. I'm going to focus on just a couple of abstracts that are related to eosinophilic esophagitis. As Eddie did, I'm going to try to keep it to the clinical importance rather than get into the basic science kind of stuff. So the first one, oral viscous budesonide versus swallowed fluticasone inhaler for initial treatment of adolescents and adults with eosinophilic esophagitis. It's really the first randomized trial of this. So what are the things we use now to treat, drugs we use now to treat eosinophilic esophagitis? They're basically proton pump inhibitors, either standard once a day dose or twice a day, topical glucocorticoids like fluticasone that is puffed into the mouth and swallowed, or budesonide. And the budesonide gets a little messy because you have to deal with respules that are liquid container, little liquid respules, and sucralose. So you have to mix that up and swallow it twice a day. It's a bit difficult. So the idea was that the viscous swallowed budesonide has a longer contact time with the mucosa, so it might be a better treatment. These are a couple of meta-analysis looking at the results of fluticasone versus budesonide, and what you see is they both appear to be relatively effective, with fluticasone overall 68% effective and budesonide 77% effective. But really before this, there have been no prospective trials that compare them one-to-one. So the hypothesis here was that oral viscous budesonide has a longer mucosal contact time such that subjects treated with budesonide will have significantly lower post-treatment eosinophil counts and dysphagia scores than those who take the fluticasone. So the study design, it was a randomized, double-blind, double-dummy clinical trial, 16 to 18 years old. It was a new eosinophilic esophagitis diagnosis. The symptoms, the inclusions were symptoms of esophageal dysfunction greater than 15 eos per high-powered field, and other causes of eosinophilia being excluded. This is an interesting trial because they allowed dilation to occur. In most trials, that's not been the case. So they were randomized 1-to-1, oral viscous budesonide. You can see the dose, it's in sucralose, and they also gave a placebo inhaler, so this is the double dummy, and that's versus fluticasone inhaler with a placebo slurry. The primary outcome was post-treatment peak eosinophil count. The co-primary was dysphagia symptoms on a standardized dysphagia symptom score. Here are the results. This is the primary outcome, peak eosinophil count. The blue bars are baseline, and the light blue is post-treatment. You can see that both budesonide and fluticasone were very effective in decreasing peak eosinophil counts, and there was no statistically significant difference between the two, and I would argue, looking at this, that there's no clinical difference either. The primary endpoint outcome was Dysphagia Symptom Questionnaire. Again, you can see that there is a striking improvement in symptoms with both budesonide and fluticasone, and there's really no difference between the two treatments. So what did we learn? Well, both of the treatments are effective. Oral viscous budesonide is not better than swallowed fluticasone, which means that either one of them is going to be an effective treatment as initial treatment for EOE. And really the choice is going to depend upon how easy it is to give the therapy, how much it costs, and both what the patient's able to do and what you guys are comfortable with. Okay, second paper, efficacy of 1 food and 4 food elimination diets for pediatric eosinophilic esophagitis in a randomized multi-site study. Now, granted, this is pediatrics, and most of us here are not pediatricians, but it turns out that just about every study, everything that's been done in EOE started in a peds population and translated very effectively to adults. So the 6-food elimination diet, this is it right here in this picture. It's very effective in producing histologic remission. However, try to take all of this out of your diet, right? That's a tough job. So when you do this, there's really a negative impact on quality of life. So the questions were, are less restrictive diets efficacious? And there's some literature on that now. And do less restrictive diets improve quality of life? In this study, they eliminated either milk as one food, or milk, egg, wheat, and soy. And the primary outcome was symptom score. Secondary outcomes were histologic remission rate, so that's less than 15 EOs per high-powered field. Histological feature score, so that's an endoscopic score, and patient-reported quality of life measures. The design was really simple. Everybody who entered had active eosinophilic esophagitis. They were randomized to either 1-food or 4-food elimination diet, and at the end of 12 weeks, they had an endoscopy with biopsies. And this is what you see. The primary outcome was symptom response. It turns out that both the 1-food and 4-food elimination diets decreased symptoms significantly, and it turns out that there really was probably not a lot of difference between the two. However, the 4-food elimination diet appeared to be a little bit better in reducing symptom scores. Secondary outcome is histological response, and the definition was less than 15 eosinophils per high-powered field. You can see that the histological response from the 1-food or the 4-food elimination diet was essentially the same. And if you look down at the bottom, 20% of the patients with either intervention had less than or equal to 1 eosinophil per high-powered field, which is really a significant result. On the right-hand side, you see the maximum peak count of eosinophils for both the 1 and 4 food elimination diets, and they're basically the same. So histological response was similar with the 1 and 4 food elimination diets. All right, we're looking at a secondary outcome, that is quality of life. And this one's, I guess, not surprising. It turns out that if you don't look at all the numbers, that's a little too complicated. It looks like quality of life improved with the 1 food elimination diet and not the 4 food elimination diet. I guess that's not a surprise to me, and I suspect not a surprise to anybody in the room. Okay. So what did we learn from this? Well, both diets reduced symptoms. The remission rate was the same with both. The peak eosinophils were decreased with both, roughly the same. And quality of life was improved more with the 1 food elimination diet. So what does that tell us? Well, it tells us that milk elimination might be a reasonable first treatment for eosinophilic esophagitis. I think this probably will translate to adults, and it's certainly not going to hurt anything to try a few weeks of a 1 food elimination diet before escalating. Then finally, a new drug that's on the horizon. It's approved in Europe. It's a budesonide oral dispersible tablet. This is a after remission trial. It's a trial to look at 48 weeks after the patients have been put in remission and continuing the drug. So in January of last year, budesonide 1 milligram oral dispersible tablets were approved in Europe. The way this works is the tablet is placed between the roof of the mouth and the tongue, and it's sort of like sucking on a hard candy for a couple of minutes to disperse it and swallow it. The previous trial, 6-week trials, showed that 58% of patients were in clinical histologic remission, 2 remissions there, I don't know why I did that, and 93% had histological remission. If they took the patients who did not go into remission and continued to treat them for 6 more weeks, 85% of those patients went into clinical remission. So quite effective therapy. The question here was, can you continue to treat them over time after remission with the same drug and see improvement or maintenance of their improvement? So in the study, all patients were in clinical pathologic remission following the initial treatment. They were randomized to 2 doses of the budesonide or placebo, and they were followed up at the end of 48 weeks. So the primary endpoint was the proportion of patients free of treatment failure at 48 weeks. And the definition is here. It's the absence of clinical response, the absence of histological response, absence of food impaction, no need for dilation, and no premature withdrawal for any reason. Secondary endpoints, the proportion of patients with histologic response greater than 15 eos per high-powered field, the mean change from baseline in EOs at 48 weeks, the proportion of patients who experienced clinical relapse, food impactions, or the need for dilation within the 48-week period, and the proportion of patients who had symptoms that were greater than expected. So here are the data. Just look at this on the left. That's the intention to treat graph. It is the percentage of patients free from treatment failure at 48 weeks. And you can see that both doses of budesonide, that is the dark and white columns, had a quite good response. And compared, they were very significantly different from what happened with placebo. The patients with placebo at 48 weeks, almost all had a return or a failure. Here we're looking at the percentage of patients with what's called deep histologic remission, that is no eosinophils per high-powered field, and it's comparing the 2 budesonide doses with placebo. The black bars are baseline, and the gray bars are after 48 weeks of treatment. And you can see that clearly the budesonide did very well compared to the placebo. Almost all of the patients lost this response when maintained on placebo. Now we have the percentage of patients with histological relapse at 48 weeks. And again, both doses of budesonide, around 10 to 15% relapsed, but those with placebo had a 90% relapse rate. And finally, the percentage of patients with clinical relapse, food impaction, or endoscopic dilation. Once again, both doses of budesonide were very effective, and there was a 60% relapse in placebo patients. What we're looking at here is the percentage of clinical remission, and the black line is placebo. The green and red lines are the 2 doses of budesonide. What we see here is that the placebo patients clearly did much worse over time. So what's this telling us? It's telling us that the oral dispersible budesonide is effective long-term therapy for patients with EOE after remission is obtained. I think the other thing that this study is telling us is that you have to keep these people on some sort of therapy. If you stop therapy, food therapy, or steroid therapy, they're going to have a clinical relapse within a relatively short period of time. Thank you.